Addressing the unique needs of persons served. Understanding disabilities. This course will educate participants about the unique needs and preferences of persons served and explore varying cultural perspectives regarding treatment. The course will assist the learner to better understand and respond to cultural differences, perspectives, and responses to treatment. After completing this training, you'll be able to make every effort to be competent in addressing the special circumstances that affect clients, understand the range of clients' reactions to challenges associated with particular special circumstances, identify the limits of your own knowledge and expertise, and evaluate personal beliefs and biases about clients who have special problems. There are many kinds of disabilities. Disabilities can be visible, hidden, permanent, or only occur at certain times. Examples of disabilities include deaf-blind, hearing, intellectual, developmental, learning, mental health, physical, speech or language, and vision. Most persons with identified mental and co-occurring disorders respond positively to treatment. Although genetics do influence the development of some disorders, mental disorders in parents do not necessarily mean the children will suffer from a mental disorder as well. Mental disorders affect one's thoughts, moods, and emotions. Early identification, completing appropriate assessments, and effective individualized care planning can make a tremendous difference in treatment. Each disorder is different, and each person expresses the disorder uniquely from anyone else. Disorders can become more or less severe and may change over time. Persons living with mental disorders can learn to function positively and effectively in their community. Violent behaviors are not associated with all disorders. Having a mental disorder does not mean a person cannot raise a child safely and successfully. Background or environmental challenges can affect the way a person expresses their disorder. Therapists should know that persons with mental disorders may become isolated from informal supports. They may not recognize their poor judgment. They may turn to negative sources of support, and persons with mental disorder may not recognize any impact on their children or other family members. Dual diagnosis refers to when someone has both a substance use disorder as well as a psychological disorder, also known as co-occurring disorders. Individuals diagnosed as dually diagnosed need to be treated for both the addiction and mental illness simultaneously in order for them to get better. What a therapist should know. It is important not to look over existing substance abuse or mental health issues. You must recognize the system. You must rule out rather than in. You should identify the cause to address the problems or behavior. You should know many symptoms can manifest in behavior issues. You should wonder what the individual is trying to tell you. And if someone appears to be in crisis, you should tell them the best way to help. You should work towards reducing any identified barriers that may keep a person from functioning at their optimal level in their community. Issues that may affect persons served include physical, behavioral, educational, and cultural. Diverse populations include, but are not limited to, Hispanics, African Americans, Hindu, person with HIV/AIDS, members of the LGBTQ communities, rural populations, homeless people, and older adults. Immigrants and refugees often mistrust authorities. They may feel extreme mistrust of government based on the atrocities committed in their countries of origin or fear of deportation by U.S. authorities. This mistrust can be a barrier to entering treatment and obtaining services. According to the U.S. Department of Health and Human Services, clients from other cultures view mental disorders, including substance abuse, much more negatively than does the general U.S. population. LGBT individuals come from all cultural backgrounds, ethnicities, racial groups, and regions of the country. Cultural groups differ in how they view their LGBT members. In Hispanic cultures, matters of sexual orientation tend not to be discussed openly. LGBT members of minority groups often find themselves targets of discrimination within their minority culture and racism in the general culture. Concerns about confidentiality and resistance to participating in group work because in small communities, everyone knows everyone else. A culturally embedded suspicion of treatment for substance use and mental disorders, although this varies widely by area. A sense of strong individuality and privacy, sometimes coupled with difficulty in expressing emotions. The combination of depression, pain, vocational difficulties, and functional limitations places people with physical disabilities at increased risk for substance abuse disorders. Clients with HIV often present with a cluster of problems including poverty, indigence, homelessness, mental disorders, and other medical problems. African Americans often mistrust, rely on faith, and go to family for emotional support rather than turning towards healthcare professionals. Mental illness oftentimes is perceived as personal weakness or some sort of punishment from God. They may be reluctant to seek or discuss mental health issues and support because of shame and stigma associated with conditions. Among African Americans with a perceived need for substance abuse treatment, 25% reported the need was unmet, more than twice the number of whites who reported unmet needs. The homeless population. They are recently displaced. Some people may be employed but have been evicted from their homes. Their housing instability may be related to financial problems resulting from substance abuse. The chronically homeless. These individuals may have severe substance use and disorders and are difficult to attract into traditional treatment settings. And transient homeless. These individuals may stay temporarily with others or have a living arrangement that involves rotating among a group of friends, relatives, and acquaintances. These individuals are at a high risk of suddenly finding themselves on the street. For some, continued living in others' residence may be continued on providing sex or drugs. Women. Treatment should be sensitive to the cultural customs and roles that females have in other cultures. It is important to understand the client's level of comfort with what is to be expected in treatment. Treatment goals should depend on the woman's hopes and should conform to the cultural role that she would like for herself. Older adults tend to feel shame about substance use and are reluctant to seek out treatment. Many relatives of older individuals with substance use disorders are also ashamed of the problem and rationalize the substance use or choose not to address it. Older individuals who do not see themselves as abusers, particularly those who misuse over-the-counter drugs or prescription drugs, are less likely to seek help. In some Asian cultures, the stigma around substance dependence is so strong that a person's substance dependency is thought to reflect poorly on the family lineage, diminishing the marriage and economic prospects for the clients and other family members. Many Native people use what they consider natural, mind-altering drugs in a sacred way under special condition and as a part of traditional rituals. However, this is very different from recreational uses of drugs for personal pleasure. Traditional Hindu does not accept the value of drugs to treat certain physical health conditions. However, it sees medications more as secondary and a temporary tool for health, not the first line or primary approach. Essential states for clients in overcoming stigma. Assume control, manage symptoms, and become an empowered individual. 2 common myths to debunk. 1. People with disabilities are inferior to normal people and their lives are very different. You have to be very careful when you're talking to a person with a disability because they are easily offended if you use the wrong word. There are 8 wellness dimensions: emotional, environmental, intellectual, financial, social, spiritual, occupational, and physical. As a therapist, you should assume intelligence. No nonverbal interactions can lead to inaccurate and harmful assumptions about a person's cognitive ability and competence. You should work to open new avenues of respectful interactions with persons served who struggle with language. You should know that if we change how we talk, we can often make positive changes. You should give the person served a chance to communicate and not just answer questions. Focusing on the strengths of a person served is an effective treatment intervention. You should be supportive. Put on a different lens and attempt to see things from the perspective of the person. Do assessments in a new way. Look at what's going right. Find out what makes the person comfortable. Look at ways to incorporate strengths into treatment strategies. What strengths can be used effectively in treatments? There are 6 respectful supportive interactions: understanding of treatment modality, self-directed choice, building relationships, encourage community membership, demonstrate patience, and understand the language. Remember, just because a person has one disability does not mean they don't have another. For example, a client has difficulty speaking. Don't assume that that client has an intellectual or developmental disability as well. Many times therapists believe they know what is best for the client. You must remember, treatment is the person's choice. Treatment is different from person to person. Reinforcement and support are essential. You must address any stressors. And keep in mind that poverty and lack of adequate housing can cause resistance to treatment. If this occurs, do not become overbearing or judgmental. Just find a different route for engagement. Barriers or obstacles, things that stand in the way of people with disabilities doing many of the day-to-day activities. Assistive devices can be put in place to minimize barriers to maximize a person's safety without compromising their autonomy or dignity. Interventions and supports. Architectural and physical barriers are features of buildings and spaces that cause problems for people with disabilities. For examples, hallways and doorways that are too narrow for a person using a wheelchair, electric scooter, or walker. Poor lighting for a person with low vision. Information or technology barriers are those barriers that cause challenges in day-to-day activities for people living with disabilities. For example, signs that are not clear enough or easily understood. Websites that don't support screen reading softwares. Attitudinal barriers are those barriers that discriminate against people with disabilities. These include thinking that people with disabilities are inferior, or assuming that a person who has a speech impairment can't understand you. Systematic barriers are those barriers that occur when an organization's policies, practices, or procedures discriminate against people with disabilities. For example, a hiring process that is not open to people with disabilities. Sexual and intimacy barriers. The desire to enter an emotionally satisfying and sexually intimate relationship and to maintain such relationships underpin the adult human experience. This includes people living with mental health and physical disabilities. It is important to work with clients on developing social skills related to the pursuit of intimate relationships, and for those clients that are interested in pursuing interpersonal relationships like anyone else. They can experience the following challenges: confusing intimacy and loneliness with sexuality, not understanding isolation, being dismissive, or not being able to address their intimacy needs. Do work to understand and accommodate the religious customs of individual clients. Do ask about a client's dietary preferences, special holidays, and religious customs. Do demonstrate religious acceptance and tolerance better. Do contact local religious leaders so they can educate you about traditions and practices and the use of mind-altering natural substances. Do educate religious leaders about services that are available. Evidence-based practices. Intervention and supports. Tips for useful interventions and supports include illness management, supported employment, assertive community treatment, medication management, counseling therapy, and residential or institutional care. The client should be informed choosers of care. They should fully participate in their treatment. They should motivate providers to improve their performance. They should encourage an effective self-care, taking preventative actions, and collaborate with providers to define and implement care plans. The provider should arm persons with evidence about treatment risk and benefits, react positively to persons who want to take a lead in their treatment, use information gained from patient assessments of care as the basis for improvement, engage patients making informed decisions to improve both quality of care and health outcomes, Tailor a care plan to the particular patient needs and continually measure how well a care plan is working. Ways to encourage client input for effective treatment. Try to find ways to provide information in a way that works best for the person. Be patient, encouraging, and supportive. If you are courteous and patient, typically the client will let you know how to best provide service in a way that works for them. Remember, when you demonstrate patience and a willingness to find a way to communicate, these are your best tools. Always speak normally and clearly and directly to the client, as they are more willing to cooperate with treatment. Do not rush. People with some kinds of learning disabilities may take a little longer to understand and respond to your questions.